Good morning, students. You have already learned pleura and lung, right? And which structures lies between the pleura? That is the mediastinum. So what is mediastinum? It is a middle space or septum lies between the two pleural cavity. But it is just the space? No, it's not just the space. It contains many viscera that will include the heart, the major blood vessels like aorta, pulmonary trunk with its branches, and the trachea, esophagus, etc. So as we say, it is a middle space. So let us say what is the boundary of that space. So anteriorly it is bounded by sternum. Posteriorly, it is bounded by 12 thoracic vertebrae with their intervertebral discs. Superiorly, it is formed by thoracic inlet, and inferiorly, it is formed by thoraco-abdominal diaphragm. And on either side, there lies a mediastinal pleura. Now, this mediastinum is further subdivided by an imaginary plane which is passing through the sternal angle anteriorly and lower border of 4th thoracic vertebra posteriorly, and that will divide the mediastinum into upper part that is known as superior mediastinum and lower part that is known as inferior mediastinum. Now within the inferior mediastinum there lies heart with that pericardium, and that will divide the inferior mediastinum into three parts. The part anterior to heart that is known as anterior mediastinum, and part posterior to heart that is known as posterior mediastinum, and heart with its pericardium that is lies in the middle mediastinum. So the inferior mediastinum is divided into three parts: anterior, middle and posterior mediastinum. And that subdivisions we can easily see in the lateral view of chest x-ray. But as we are going to see the content of each part, we know that the anterior mediastinum is contain almost negligible structures, or some structures which is lies within the superior mediastinum is extending into that anterior mediastinum. So surgically it is considered that both are in the same part, antero-superior mediastinum, and the posterior part of superior mediastinal content, they are same which is extending into the posterior mediastinum. So the whole posterior part is considered here as a posterior mediastinum. So surgically we have a three: antero-superior, middle and posterior mediastinum. Now let us see the superior mediastinum first. So what is the boundary? Anteriorly it is formed by manubrium sterni. Posteriorly, it is formed by upper 4 thoracic vertebra with their intervertebral disc. Superiorly, it is formed by thoracic inlet, and inferiorly, it is formed by imaginary plane passing through the sternal angle. And on each side, it lies a mediastinal pleura. Now, what are the content? It contains so many structures: the viscera, muscles, vessels, lymphatics, nerves. So how will you remember? You can remember by that figure that you have learned in that your first chapter figure, that is a transverse section at thoracic inlet, and that can be asked as a draw and label figure. So let us going from anterior to posterior. There lies a sternohyoid muscle, sternothyroid muscle. Further posteriorly, the remnant of thymus. Further behind, there lies an inferior thyroid vein. Further posteriorly, there lies a trachea. Further behind, we have a esophagus. And between trachea and esophagus, there lies a left recurrent laryngeal nerve on the left side. And further posteriorly, thoracic duct. And if you go further posteriorly, there is a prevertebral part. So here the muscle is longus colli muscle. Now if you go from sideway, there lies a neck of first rib with their relation. So they are from medial to lateral sympathetic chain. first posterior intercostal vein, superior intercostal artery, and ascending branch of ventral primary rami of first thoracic nerve. Now if we go on the further anteriorly, on side way of the trachea, we can found in the lower part we have arch of aorta, and in upper part the three branch of arch of aorta, they are brachiocephalic trunk, left common carotid, left subclavian. So left subclavian, left common carotid, and brachiocephalic trunk. If you see the major veins, in lower part there lies a superior vena cava, upper part right and left brachiocephalic vein. So right and left brachiocephalic vein. Now between the major blood vessels there lies a phrenic and vagus nerve on both the sides. And further anteriorly, just parasternally, we have lies a internal thoracic vessels. And further laterally, if you can see, there lies an apex of lung and cervical pleura, which is lies in the lateral aspect, but it is not can be included into the superior mediastinum because it's between the two pleural cavity. Some will divide that content into retrosternal, intermediate part, and the prevertebral part. So whatever way you can lie, remember it's you, up to you. Now the inferior mediastinum, that inferior mediastinum, as we know, it is divided into anterior, middle, and posterior mediastinum. So let us first see the boundary of anterior mediastinum. Anteriorly it is bounded by body of sternum. Posteriorly it is bounded by pericardium. Superiorly it is bounded by an imaginary plane, and inferiorly it is bounded by thoraco-abdominal diaphragm anterior part, and on each side there lies a mediastinal pleura. Now what are the content of anterior mediastinum? It is containing superior and inferior sternopericardial ligament through which heart is anchored to the sternum. In addition, it is containing some retrosternal group of lymph node, that mediastinal branches of internal thoracic artery, lower part of thymus, and loose connective tissue. Now the middle mediastinum. The middle mediastinum, how it is bounded? Anteriorly there is anterior layer of pericardium, posteriorly posterior layer of pericardium, superiorly there is an imaginary plane, inferiorly it is a diaphragm which is fused with the fibrous pericardium, and on each side there lies a mediastinal pleura. Now what are the content? The content is that is major, it is heart with the major blood vessels arising from or draining into it. They are aorta, that is ascending aorta, pulmonary trunk with two pulmonary arteries, the superior vena cava and the terminal part of that inferior vena cava also, and few lymphatics. They are lies in the middle mediastinum. And now they lies are phrenic nerve and pericardiophrenik vessels, and just beneath the arch of aorta there lies a cardiac plexus. Posterior mediastinum. What are the boundaries of posterior mediastinum? Anteriorly it is formed by posterior layer of fibrous pericardium. Some will include that the diaphragm is sloping one, so that may be forming a lower part of anterior boundary. Posteriorly it is formed by 5th to 12th thoracic vertebra with their intervertebral disc. Superiorly there is an imaginary plane, and we can consider it inferiorly as a thoraco-abdominal diaphragm. And on each side there lies a mediastinal pleura. Now what are the content? There are again the viscera, vessels, nerves. So viscera, that will include trachea, esophagus, the vessels that will include that descending thoracic aorta with its branches, pulmonary arteries, the major nerves that will include the vagus nerve with their cardiac plexus branches, sympathetic chain with their autonomic plexuses. So how will you remember? Let us going from posterior to anterior. That is a vertebral column with its anterior longitudinal ligament. Now we are moving anteriorly. So there lies paravertebrally sympathetic chain. Between it there lies azygous venous system. Further anteriorly, the thoracic duct, which is usually lies on the right side. Now it is going to be crossed at the level of fifth thoracic vertebra towards the left side. Further anteriorly, descending thoracic aorta with its branches. Further anteriorly, if we go, there lies esophagus and trachea with autonomic plexuses that will be formed by vagus. And further anteriorly there lies a posterior layer of pericardium. So that is limiting that boundary of posterior mediastinum. So these are all the content of posterior mediastinum. Now let us see the clinical anatomy related with the mediastinum. That can be asked as a short note question. So let us start first. As we have seen, in the mediastinum, right side there lies a major vessels in veins, while left side there are arteries. So veins are collapsible, so there are more space in the right side, and that dead space will allow the increased venous return so that veins can be dilated. But simultaneously, that is also a site where any tumors or any space occupying lesions will ultimately going to protrude on the right side where there is a more dead space. Now you have already learned the deep cervical fascia, the three layers, the investing layer, that blue color, that yellow color, that is a pretracheal fascia, and the pink color, that is a prevertebral fascia. Now if we see the extension, that pretracheal fascia is extending up to the arch of aorta. While if we go into the prevertebral fascia, that prevertebral fascia is extending up to fourth thoracic vertebral level. So it is extending almost up to the superior mediastinum. Now if you already remember that prevertebral fascia is divided into alar fascia and prevertebral fascia proper, within which there lies a retropharyngeal space. So that prevertebral fascia is attached at the fourth thoracic vertebra, and in front of it there is a retropharyngeal space in the neck, which is ultimately going to communicate with the superior mediastinum, and from the superior to the inferior mediastinum posterior part. So that the infections can spread from retropharyngeal space to the superior to the posterior mediastinum, and if only the infection occurs in the beneath or posterior to the prevertebral fascia, it can extend only up to the fourth thoracic vertebra, that is up to the superior mediastinum. And if it occurs in front of that pretracheal space, it is also extending into the superior and anterior mediastinum. The space occupying lesions means there is some mass which is ultimately increase in size. That may be of many. Either it may be a lymph node enlargement, either it is a blood vessels enlargement that may be due to venous engorgement, or there may be an aneurysms, or there may be a tumor of the surrounding structures. So that space occupying lesions are so many. There are end of lists, but what happens is that space occupying lesions will ultimately compress the nearby structures, and that will be causing mediastinal syndrome. So if it is compressing the trachea, that leads to dyspnea, cough, breathlessness. If it is compressing the superior vena cava, the venous return is hampered. So what happens? Venous engorgement and edema occurs in the upper half of the body, including the upper leg. Now, if it is involving the esophagus, it will lead to difficulty in deglutination, that is dysphagia. If it is involving the left recurrent laryngeal nerve, which will supply the larynx, so it will lead to hoarseness of voice. If it is involving the phrenic nerve, that side of diaphragm is paralyzed, so it leads to hemidiaphragmatic paralysis. Now, if it is involving the corresponding intercostal nerve, it will causing radiating pain along that distribution, causing intercostal neuralgia. And ultimately, if can compress the vertebral column and causing erosion of that vertebra. Now, the mediastinal shift. Now, due to pathology of lung or pleural cavity, mediastinum may move from its original position, that is known as mediastinal shift. That may be due to the lung pathology of one side, like a pneumothorax, which is going to push the mediastinum to the healthy or opposite side. But it is not always shows that it should be shifted to the opposite side only, or healthy sides only. You can see that is emphysematous lung will pushing the mediastinum on the right side. But it is not so, because sometimes that atelectasis or fibrosis of the lung, which will causing reduction in the size of that side of the lung, so that will causing shifting of the mediastinum on the affected side or same side also. And how will you measure the mediastinal shift? That will be measured by palpation of trachea within the suprasternal notch. You can palpate the trachea and you can insinuate the finger between the trachea and sternocleidomastoid. It can be easily gone than it is in a middle position. And that can also be assessed by a 3-finger test. In the middle finger, you can inspect or palpate the trachea, and in the index and the ring finger, you can insinuate between the sternocleidomastoid, and on any side, if it cannot be insinuated, that side of mediastinal shift can be indicated. Mediastinoscopy, usually it is a cervical mediastinoscopy that will be usually commonly done for tracheobronchial or bronchomediastinal group of lymph node. Biopsy can be taken by this route, or some surgeries can be done. That is done by in the suprasternal notch. We can put an incisions and introduce that mediastinoscope up to that bifurcation of the trachea, where we can find a bronchomediastinal lymph node, and we can take a sample or biopsy from that. So one way is the mediastinal biopsy through that mediastinoscopy. Another one is through endoscopy by transesophageal. So we can do a transesophageal endoscopy and we can do a mediastinal lymph node biopsy through. But what we have to take it in consideration is lobe of azygous vein. It is one of the variant of congenital anomalies of that lobe. That is usually right side of the lung apex is developed on the lateral to the azygous vein, but sometimes some part is developed medial to the azygous vein, and so that azygous vein is suspending like a mesentery, and the part of that lung or apex of that right lung is known as lobe of azygous vein, which is in X-ray it looks like a hilar lymph node enlargement. And so that although it's a azygous vein, we can consider it as a lymph node, and if you're going to take a biopsy from that, it is causing alarming hemorrhage. So we have to take it consideration of that things